Hi guys, welcome back. I think it's going to be a short session and we'll be finishing in 1 hour as much as possible. Yeah, and we'll be discussing on approach to anemia. Most of you guys will be knowing this already, but I'm just going to discuss the basics today. So later on, when there is time, we might be discussing about some advanced concepts, but right now it's going to be only with regards to the basics, nothing more. And just going to the first slide, everyone knows about where the hematopoiesis starts when you're not born and after birth, how it's going to progress. So in the prenatal period, the first site where the hematopoiesis is going to start is going to be the yolk sac, everyone knows. And then your yolk sac tends to regress by around 2 weeks to 2 to 3 months, by around 8 weeks time. Then your other organs like liver and spleen are going to take over. So liver and spleen will be the major sites of hematopoiesis by around 3 months mark, and the liver and spleen also tend to regress just before birth, and then the bone marrow is going to take over. At the time of birth, the most important site of hematopoiesis is going to be the bone marrow, of course. And after your birth, the flat bones, initially you're going to have a lot of hematopoiesis with regards to the long bones as well as the flat bones. But initially the long bones will be taking part equally in hematopoiesis, but as time progresses, your long bones tend to regress as well in terms of hematopoiesis, where you're going to have hematopoiesis only in the flat bones, like sternum, ribs, or probably in the vertebra. So in the adulthood, the most important sites of hematopoiesis are going to be the vertebra, sternum, and probably the ribs. These are very important points, and any of this can be asked in exams also. When it comes to SSA exams, you tend to ask these kind of basic concepts as well. So what do you need to know? Beginning, you start with the yolk sac, then it's going to be the liver and the spleen. That's going to the major site. By around 4 to 5 months, your bone marrow starts to participate in hematopoiesis, but by around 8-9 months, it becomes the major organ. And at birth, it's the major organ that's going to participate in hematopoiesis. And in the bone, if you look at the time of birth, almost all the bones, including long and flat bones, are going to take part in hematopoiesis. But by the time you reach your early 20s or late 20s, by the time your long bones are going to regress, only flat bones are going to participate in hematopoiesis over a period of time, including vertebra, of course. So this is a simplified overview of what's happening with regards to hematopoiesis. So first, you're going to have something called as stem cell. You know the stem cell marker, right? It's going to be CD34. So with the help of stem cell factor and interleukin-3, stem cell tends to differentiate into something called common myeloid progenitor. And with the help of interleukin-7, it tends to differentiate into common lymphoid progenitor. So from the common myeloid progenitor, you can get a variety of cells like what you're seeing here. So it can differentiate into mast cells, it can differentiate into basophils, depending on certain important cytokines and factors. It can differentiate into eosinophils. The most important here, though, is going to be the IL-3 and IL-5. Especially IL-5 is very, very important for differentiation into eosinophils. Then it can differentiate into neutrophils. For that, you need GCSF, interleukin-3 and 6. It can differentiate into monocyte. It can differentiate into megakaryocyte. So to differentiate into megakaryocyte, you need the thrombopoietin. Everyone knows that. But many people do forget this interleukin-11. Interleukin-11 is also very important for differentiation of platelets from a megakaryocyte. That's the reason why we have a recombinant interleukin-11 molecule that's called as operalvekin, which can be used in chemotherapy-induced thrombocytopenia. And with regards to erythropoietin, it's going to result in production of RBCs. We know that because EPO is very, very important for maturation of RBCs. So let us concentrate only on this area right now, because others are not important as of now, because we're talking about anemia and maturation of RBCs. On the other side, you're having the common lymphoid progenitor, which can become a natural killer cell or a B and a T cell, or sometimes both. Your lymphoid progenitor as well as myeloid progenitor can result in the formation of dendritic cells as well, because dendritic cells can be formed from innate as well as adaptive immunity. And in the adaptive immunity, it can be coming from either the lymphoid progenitor or from the innate side. It could be from the myeloid progenitor as well. So what is the name of the drug you want to know? Okay, fine. So I thought like everyone knows it. So there is an interleukin-11, recombinant interleukin-11 molecule that is called as operalvekin. This is not approved for treatment in idiopathic immune thrombocytopenic purpura, but this can be used in patients who are having chemotherapy-induced thrombocytopenia. For them, operalvekin is approved as of now. And we have a variety of such molecules. For example, we have TPO mimetic. I don't know how many of you know the TPO mimetics. Can anyone name what are the TPO mimetics? One drug that's very important. What is the TPO mimetic that you know? Yeah, no. L-trombopag is a TPO receptor agonist. You're talking about TPO mimetic. It's romiplastin. So romiplastim is a TPO mimetic. What you're saying is L-trombopag and avatrombopag, which are TPO receptor agonists. All right. So what are the recombinant GCSF? What are the molecules you have? We have filgrastim and pegfilgrastim, right? Filgrastim and pegfilgrastim, pegylated form. So that's nothing but GCSF. And we have the recombinant GM-CSF also, that's sarcomastin. So we can make use of this pathway, cytokines, and you can stimulate any pathway for that matters. And each and everything becomes important in certain selected diseases. Right now, it's not important because you're talking about anemia. So let us concentrate only on this area. So how RBCs are going to mature. So if you look at the maturation of the RBCs, initially it's going to be something called as an erythroblast. That's a CFU or colony forming unit erythroblast. It's going to become something called as proerythroblast. Then it's going to become something called early normoblast. Then becomes your intermediate normoblast. Then comes your late normoblast. And finally, you get the reticulocyte stage. And then you end up with mature RBCs. Right. So in what stages you need erythropoietin? From what stage to what stage you need iron? From what stage to what stage you need B12 folate? And from what stage to what stage you need the hormone influence to result in maturation of RBCs? For all these things, you have an answer in this particular slide. So for example, if you look at erythropoietin right from your CFUE till the intermediate normoblast stage, you need erythropoietin. So if you give erythropoietin, you're going to result in stimulation of all these precursor cells, result in the more production of all these precursor cells. And where iron is required, iron, even though it's not really required for the CFU stage, from the proerythroblast stage itself, you need iron till it becomes a reticulocyte stage, iron is generally required. So that's the reason why before giving erythroid stimulating agents, maybe in patients who are having anemia of chronic disease or patients who are having erythropoietin deficiency due to some reason, before giving erythropoietin, it's important that we rule out iron deficiency. So if the patient is having already iron deficiency and if you're giving any erythroid stimulating agent, it won't really work because iron is very, very important for crossing these stages. If you give only erythropoietin and if the patient is having severe iron deficiency, how you expect the RBCs to cross these stages? They won't mature at all. That's the reason. One important thing is before giving any erythroid stimulating agent like epoietin alpha or darbepoietin alpha or pegylated methoxypoietin beta, it's always important that you give iron. If the patient is having iron deficiency, we have to check for it. Then only we can replace. Then only we can give erythroid stimulating agents. And where your B12 and folate will be required, especially in the first three stages, in the CFUE, proerythroblast, and early normoblast, you need B12 and folate because it's very, very important for DNA synthesis. That's why. Suppose if you do not have enough B12 or enough folate, you result in megaloblastic anemia. The reason for why you get megaloblastic anemia is because they cannot progress to subsequent stages. And these are the cells that are going to be very big and they're going to have a prominent nucleus. And these are what we call it as megaloblasts. And they will accumulate in the bone marrow. And sometimes they can leak into the peripheral blood as well. And where your hormonal influence is going to push in the intermediate and the late normoblast stage. At this stage, hormones like thyroxine and even androgens, and some people do believe in cortisol for that matters, is very, very important for crossing these stages. I mean, it's not really important for like proper maturation, but it's going to accelerate the maturation. That's it. Probably that is the reason why males generally tend to have a slightly higher amount of hemoglobin compared to that of females. That's because of the androgenic influence. And you can also understand why patients who are having hypothyroidism tend to develop a macrocytic anemia commonly, because they don't proceed forward. The maturation again is going to be not that great in patients with hypothyroidism. Even patients with hypoandrogenism, you tend to see macrocytic anemia. Probably this could be the reason. So now you can understand how these factors, hormones, iron, B12, folate, all tend to play a lot of complex role in the maturation of erythroblast into subsequent stages. Finally, you get the mature RBC that's going to be seen in the peripheral smear. In the peripheral smear, what you're going to see is only the reticulocyte and the mature RBCs, right? The normal reticulocyte count will be 0.5 to 1.5%. That's it. There's a normal reticulocyte. So generally, but what we need to do is we have to see something called reticulocyte index. We'll talk about that in a while. So in the peripheral smear, you don't see anything apart from mature RBC and reticulocyte. If you see anything else, it's kind of abnormal. And you can also notice here what's happening. So in the initial stages, your hemoglobin will be very low and all of a sudden it's going to massively spike up. But over time, what happens is your RNA, DNA and all will keep coming down. So in a mature RBC and reticulocyte, you don't see nucleus at all. Till your late normoblast stage, you're going to have a nucleus. However small or big it may be, you're going to have a nucleus. But once you reach that reticulocyte or a mature RBC stage, you no longer have a nucleus. So if you see a nucleated RBC, even that is also kind of abnormal. Usually nucleated RBCs, if you see in exams, it typically tends to tell about something called as a leukoerythroblastic picture. Leukoerythroblastic picture.